Welcome to the Better Breathers Club meeting, COPD control during the COVID-19 pandemic. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters. And make sure the media player on your screen is enabled. If you are having any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. Now let's begin the webcast. As a reminder, the presenters cannot give medical advice during the webinar. As always, consult your personal physician or healthcare provider with any questions you may have regarding your specific medical condition.
Welcome to today's webcast, COPD control during COVID-19. We're glad you're here. My name is Liz Hall, Health Promotions Manager at the American Lung Association, and I'll be the facilitator for today's call. For more than 115 years, the American Lung Association has been the champion of healthy lungs and healthy air. Today, our work is more important than ever. COVID-19 has brought challenges to communities both across the country and around the world as we all try to adjust to a new normal. During today's webcast, we will share some guidance and tools to help you manage your COPD during the COVID-19 pandemic. We remain steadfast in our mission of saving lives by improving lung health and preventing lung disease through research, education, and advocacy. I would like to acknowledge Theravance Biopharma for their support of this webcast. Our overall goal for this project is to improve COPD management by educating patients living with COPD on the strategies that can help them achieve and maintain optimal COPD care, while taking science-based steps to reduce the risk of COVID-19 from spreading. This webcast, along with many other initiatives broadly described on this slide, are all part of our COVID-19 Action Initiative, a new $25 million investment to address COVID-19 and protect against future respiratory virus pandemics. The initiative will work with public and private entities to increase research collaboration and develop new vaccines, detection tests, and treatment therapies. Let's have a look at our agenda for today. We intend to cover 4 main topics during our session on COPD control during COVID-19. Measures to prevent infection by the virus that causes COVID-19. COPD medication and management, including information about medication shortages, financial assistance, and nebulized care. Stress management, and emotional connectivity. Please know you can also download today's meeting agenda from the resource widget. As we move through the session, feel free to enter your thoughts and questions into the Q&A box. We are very fortunate today to be joined by 2 members of our patient advisory group, Karen and Mike, who will serve as our member audience. Throughout the webcast, we'll be asking them to share their experiences with the group. As part of our listening audience, I encourage all of you to type in your comments, and I'll weave your thoughts into the conversation. Now let's begin with a question for Karen and Mike. Karen, would you please tell us a little bit about yourself and how you're doing today?
Well, I live in Florida. I have COPD. I was diagnosed back in 2001 as severe, but I've been very fortunate. I've been able to keep it under control. I'm doing okay. The weather in Florida is awfully hot, as I know it is all over the U.S. right now, hot and humid. So I'm not getting out as much as I would like to, But by and large, I'm doing fine, and I'm glad to be part of this program today.
Thank you, Karen. We are really glad to have you with us today. Mike, would you share just a little bit about yourself with us and how you're doing today?
My name is Mike, a 64-year-old, live in Southern Illinois. Today's a great day. It's only 84 with low humidity in St. Louis. I'm in the St. Louis, Illinois, Southern Illinois region. Normally it's 98 with 100% humidity, so it's 120. And it's, just like Karen, Southern Florida or Southern Illinois, either way. Today I'm doing great. Like I said, it's only 84 today, so it feels like spring.
Thank you, Mike. It's wonderful to have you on our call today as well. Let's get started. I am pleased to have joining us today Dr. Albert Rizzo, our Chief Medical Officer. He's board certified in internal medicine, pulmonary, critical care, and sleep medicine, and is a clinical assistant professor of medicine at Thomas Jefferson University Medical School in Philadelphia. Dr. Rizzo is responsible for ensuring that the American Lung Association is always using the best science and medicine to formulate and deliver on our mission. Dr. Rizzo, thank you for joining us.
Thank you, Liz. We'll go to the next slide, and I want to thank everybody for joining us today. We're going to go over some of the basics of COVID-19 first. You probably have heard too much about this condition over the last 6 months, but it never hurts to talk more about it because we are learning different things about it as the weeks go by. We know that at its core, it's a respiratory infection. It's mainly transmitted by respiratory droplets that we inhale through our nose or mouth or by touching the mucous membranes of our eyes, nose, or mouth. Person-to-person spread is unfortunately how it does spread. And the symptoms that when they occur tend to be early on, they were mainly fever, cough, and some shortness of breath. But now we know there are other constellation of symptoms of fatigue, achiness, loss of smell, some GI symptoms. So it really is a presentation that can be very hard to determine in some people. And we know that some people have very mild symptoms, if any at all. The symptoms may appear anywhere from a couple of days to as long as 2 weeks after exposure, and that becomes an important thing to remember when you're worried about contact tracing and exposing other people to a potentially infected source. One other thing we've learned about COVID-19 is that there are definitely disparities occurring. This slide reports the number of hospitalizations. Several cities have reported higher rates of complications and deaths from COVID-19, particularly among African Americans. These reports reflect the persistent inequalities in resource allocation, access to health care, and other health stressors that communities of color experience. It also highlights the underlying racial disparity in the burden of lung disease among African Americans who experience higher rates of asthma and lung cancer. Individuals with chronic medical conditions, while not more likely to contract COVID-19, could have more severe symptoms if they do become sick. These hospitalizations and deaths continue to increase nationwide, and some communities bear a disproportionate burden, most significantly impacted the American Indian and Alaska Native, non-Hispanic Blacks, and Hispanic or Latinos. As I said on the last slide, there are individuals who are at higher risk of developing complications. Certainly, the older you get, the more at risk you are. And again, this doesn't mean you're at risk for getting the infection. This means that if you get the infection, you're more likely to have a complication or a more severe illness. The other things that are listed on that slide include other chronic diseases besides lung disease, heart disease, diabetes, cancer, and even obesity by itself is a risk factor. We also know that because the immune system is so impacted by the COVID-19 infection, people who are already taking drugs that affect the immune system may be at higher risk of complications as well. But we also know there's a lot of indication that people who smoke, because of the airway inflammation, have a higher risk of COVID complications. And we're not sure completely about vaping, but the suspicion is that that also does lead to a higher risk of complications. We just don't have as much evidence on vaping as we do cigarette smoking. On this slide, you see a number of the ways you can prevent getting COVID-19, and many of them are common sense, so staying away, staying home and staying away from people who potentially are sick, and especially since we know people can be carriers of the virus and not know it. and that's why the masks that we'll talk about later on are being so heavily recommended. When you are out in public, do the spatial distancing of at least 6 feet. That's the amount of distance that we think respiratory droplets will come out of somebody's mouth when they speak, talk, sing, cough, sneeze, and then drop to the ground. So if you're outside that 6-foot area, chances are you're not going to inhale that respiratory droplet. We also recommend don't touch your nose, eyes, or mouth, mainly because the mucous membranes is where the virus tends to enter the body. If you do cough, sneeze, cough, cover your mouth, cough into your elbow if you have to, and use tissues. Wash your hands frequently. There's some evidence that surfaces can contain the respiratory droplets for a period of time and may be infectious that way. So the topic of masks has been in the news a lot lately. Mandates for masks, do we wear a mask, do we not wear a mask? I think the important thing to remember is that the mask recommendation comes out of the concern of protecting others from people who have the virus and don't know it. So the facial coverings are to keep your respiratory droplets from coming out and infecting other individuals. It's not so much that the mask is protecting you from inhaling the virus. Various masks are pictured on the screen. The one at the top left on the left is the N95 mask, which is the most effective in preventing inhalation of viral particles, but this should be maintained for the frontline workers because of scarcity issues. And this is also a little bit harder to wear for a period of time for anybody who has an underlying lung problem. The other facial coverings tend to be more comfortable. They do a good job of keeping the respiratory droplets from coming out of your mouth when you cough, sneeze, talk, or sing. And they're not as effective as far as filtering the virus in, but again, that's not why you're wearing the mask. The best way to avoid getting COVID-19 is the isolation, spatial distancing, and staying away from sick people. There may be some role for face shields. The main thing the face shield adds to the situation is covering the eyes and mucous membranes, but there's not enough evidence to say that the face shield by itself is best to prevent your droplets from being spread to other people. So the mask is still the best recommendation from the standpoint of the public health standpoint and the CDC. A few weeks ago, because of questions that many physicians and patients were having with regard to masks and is it safe to wear a mask if I have a chronic lung condition? Should I get an exemption? And 4 organizations led by the American Lung Association, along with the COPD Foundation, the American Thoracic Society, and the American College of Chest Physicians, put out a joint statement saying that the N95 mask should be reserved for frontline workers and that generally very few people with chronic lung disease will be impacted by having to wear a mask. The real distinction here is that if you are concerned about your health and wearing a mask, talk to your physician. Very few people with lung conditions can't wear a mask because the mask does not inhibit the flow of oxygen and carbon dioxide. The masks have not been shown to affect an individual's level of carbon dioxide or oxygen in almost all the cases. There are very few individuals who have significant enough disease where that makes a difference, and those are the individuals who should not be out in public having to wear a mask in the first place. So to sum up here, COVID-19 is not going to go away for quite a while. We're not sure. Some people, including Dr. Fauci, think it's here to stay. It may show up as a yearly virus as the influenza. We just don't know. It's been with us now since earlier this year, and there's a big concern that's going to be continuing for a while until there's enough people who are infected by it and get herd immunity or have vaccines. And really, that's another question as to when that's going to occur. So I'm going to turn it back to Liz, I believe, at this point, or not. Yes.
Thank you, Dr. Rizzo, for all of that amazing information. Let's turn now to managing COPD amid COVID-19. Let's start with a fun audience polling question. Karen and Mike, in just a moment, I'm going to ask you how well each of you feel that your COPD is controlled. While you're thinking about that, let's get the audience started on the same question. While Karen and Mike are thinking about their responses, it would be great to see how all of you, our audience, are feeling. Please let us know how well you feel your COPD is controlled during the pandemic by clicking on the circle of the response you think most applies to you. Your choices are, my COPD remains under control, I experienced 1 or more COPD exacerbations, but I was able to manage the flare-up at home, I experienced one or more COPD exacerbations, and I had to go to the emergency room or hospital to get my symptoms under control. If none of these apply to you, choose other, and then type your response into the Q&A box. Again, please click on the circle of the response that best captures how you're feeling. Mike, I'd love to check in with you first and see how well you feel your COPD is controlled during the pandemic. How would you answer that question?
At this present time, my COPD is, knock on wood, is under control. I don't have too many issues where I need my nebulizer or my albuterol. It's one of those things where if I feel something's coming on, you just slow down. I think the other day when we were talking, I told you I've only had to use my albuterol, I think once or twice in the last year and a half, but once was about 2 weeks ago when I was in the hot morning sun and humidity and doing some yard work at the place that I manage, and it was one of those, the worker with me said, okay, Pops, it's time to take your breathing thing. So he went in my truck and got my albuterol. I took a hit and I slowed down. For the most part, I'm not on oxygen yet. For the most part, it's controlled pretty well. You just have to manage what you're doing, and you can't do anything stupid. And I hate to say it like that, but you'll know when you're doing something wrong, you won't be able to breathe.
Thanks, Mike. We really appreciate your sharing about your experience with us. It's really helpful. Karen, would you please let us know how you're feeling how well you feel your COPD is controlled during the pandemic?
Sure. I actually think it may be controlled even better than normal, because while I've always been very cautious about people that I'm around and being, going out in public when I know, that people have been sick, because of the pandemic, I'm bending over backwards not to go out. I don't go to the stores anymore. I have delivery, or I do curbside pickup with groceries, with the stores, with drive-through pharmacy. So I'm actually being exposed far less than I normally would be. Normally, I probably would have had, the start of a mild exacerbation at least once by now, but I haven't. And so maybe in my case, it's terrible to say, but the pandemic, being forced to stay quarantined or in isolation, has been a good thing for my COPD. But kind of tired of it, as everybody is, I'm sure.
Absolutely. Thanks, Karen. Your perspective is really important, and I know everyone values hearing it. Now let's check in with our audience and see how all of you listening responded to our question. This is great. 57.9% of you say your COPD remains under control. Another 13.2% said you experienced one or more COPD exacerbations, but were able to manage the flare-up at home. That's great. A few of you did have to go to the emergency room and hospital. It was just 2.6%. And there are some others, and I see that one of you on the call today is an educator. We are glad to have you. It's wonderful to have folks that are out trying to help other people learn about COPD and how to manage it during COVID-19. So, yeah, that's about it. We did get some wonderful questions I'm going to be holding until the end when we have a nice general question and answer period with Dr. Rizzo. So thanks for submitting those. Dr. Rizzo is now going to offer us some great information about how to manage COPD during the pandemic. Dr. Rizzo, the floor is yours.
Thank you, Liz. I just want to comment on the last comment that, well, first of all, I'm glad so many of you are doing well with your COPD. And even earlier today when I was seeing some patients, they all attribute it to the fact that they're really watching who they're around. They're staying isolated from people. They're washing their hands more frequently. And all of this is what we used to do every year around flu season. And this is just good general practice to try to prevent infections from occurring. So maybe some of this will stick with us for the times ahead. And certainly as we move into influenza season with COVID-19, all these things we've been doing are going to be even more important. And on the slide, you see some just general advice around general lung care, not just if you have COPD or asthma, but people to keep their lungs in good shape. Try to make sure you get your influenza vaccine every year and make sure your pneumonia vaccines are up to date by talking to your physician about that. Obviously, if you have been smoking, please quit. And if you're vaping, please stop vaping. Even avoiding secondhand smoke is very important. We know that that can exacerbate underlying chronic lung conditions like asthma or COPD. Many of you on this call, if you're Better Breathers participants, you probably have also been participating in pulmonary rehab programs. And really the key there is that the regular amount of exercise on a daily or several times a week basis to maintain conditioning, to not lose muscle tone is very important, because your lungs are a bellows. They have the muscles around them to kind of inflate and deflate. So keeping yourself in as good a shape as possible. That doesn't mean you have to be a marathon runner, but doing some regular exercise, walking to the mailbox, doing a flight of stairs periodically, all that is very important. And it's also important when you have a chronic condition, whether it's COPD or other chronic condition, is to realize that you need to approach it with some stability in your emotional status from it. It's very anxiety-producing to have shortness of breath. There's no question about that. And really, it's an important thing to talk about with your caregivers, with your physician, to help maintain an even keel, especially during times when things are getting more stressors around than usual. And the last thing on this slide is an important thing as far as communication with your healthcare provider. Nowadays, with telehealth, electronic portals, emails, keeping in touch with your treating physician with regard to changes in your symptoms is very important so that intervention can occur appropriately. Over the last probably 8 months now, we've heard a lot about lung disease in the news. COVID-19 has primarily, as I said earlier, at its core, it's a respiratory disease, although it affects the rest of the body. So a lot of talk about medications around lung disease, COPD and asthma in particular. And early on, there was a lot of discussion about the availability of metered-dose inhalers. You may understand or have heard in the news that hospitals started using metered-dose inhalers much more readily than using nebulizers. The main reason for this is when a nebulizer is used in a hospital room, it creates aerosols, which have smaller particles than the typical respiratory droplets that come out when we cough, talk, or sneeze. Those smaller aerosols stay suspended in the air for a longer period of time and are more likely to cause infection in people who come into that room. That's why it's so important for the N95 mask to be used by frontline workers when they're in areas where aerosolization occurs. That occurs when nebulizers are used, ventilators are used, BiPAP machines, CPAP machines. So all those things led to hospitals switching from nebulizers to metered-dose inhalers, and that in some areas did lead to some shortages. So it's important to keep those on hand, make sure they're up to date. I'm glad you're not using them often enough, and it means you're stable, but don't let your metered-dose inhaler expire. Keep a fresh one available to you. And on this slide, you see the different devices that have come about over the last 10, 15 years. And having these choices is good. Not every device works for every person. Each device has different molecules in them, different types of medication. So it's important to work with your physician to make sure you're on the right device with the right medications. And it's not easy to say, well, you could use a pill for many of these drugs, many of these conditions, but by and large, inhaled medicines work effectively in the lung, primarily just affecting the lung and cutting down on side effects that are outside the lung. But one drawback of using inhaled medications is it's notorious for these medications not to be used correctly. And when I ask my patients about how often do you get shown how to use these inhalers, very often they say not very often. Prescription is written, you go to the drugstore, you pick it up, and sometimes the pharmacist will ask if we can show you how to use it. Many times the physician's office doesn't have the time or the manpower. But you should ask your physician if you're using it correctly, because if you're not, it's not going to be delivering the drug into the area where it makes a difference. And study after study has shown as much as 30% of people make a wrong step with regard to using whatever device they're using that I showed you on those previous slides. So that's important to go over that with your treating physician. In addition to the general medical lung health I mentioned earlier, you need to try to make sure you're using your medication as prescribed. Many times in COPD, there are maintenance medications just like there are in asthma. Maintenance medications in COPD tend to be primarily bronchodilators, but those who have had exacerbations may be on inhaled corticosteroids as well, and those should be taken daily. There are also rescue medications. The metered dose inhalers like albuterol that we mentioned earlier are used on an as-needed basis. Try to keep your prescriptions up to date. If it's more convenient, use mail-order pharmacy so you don't have to go out and worry about wearing a mask. And talk to your provider about how to get them refilled automatically if possible. And certainly work to get a more affordable, potentially 90-day supply. For many people, it's more affordable than getting it on a monthly basis from a local pharmacy. But again, that varies from person to person and varies depending on your insurance. Let's talk a little bit more about nebulizations. I mentioned about it in the hospital being a concern. That doesn't mean you can't use a nebulizer in your own home. What I would advise, however, if you are living with other individuals, and potentially if you have the virus and don't know it, you want to use that nebulizer in a room where you can be confined for a period of time, where the room can be sealed off for a period of time to let those small aerosols fall to the ground so that people coming into that room don't potentially inhale it. So you can use your nebulizer the same way you would otherwise. Just make sure it's a well-ventilated room. People can stay out of it for a period of time and just not potentially expose other people to your aerosol and droplets. Okay, did I skip a slide here or not? We go back one. No? So these are some resources to look at with regard to information about how to use the nebulizer. There's also some videos and information regarding the appropriate use of the different devices that we mentioned before, as well as supplemental oxygen. If you're still smoking, certainly there's help regarding tobacco cessation. The American Lung Association has the Freedom from Smoking online, which can be very helpful. And as part of what we're doing today, we do have online support groups, better breather groups, and the Inspire community is a sponsored by the American Lung Association, and is a large group of individuals with COPD who share information on that site as well. And the next slide gives you some tips as far as assistance programs. We can make this available to you with the webinar following this, but these are places to go. Many pharmaceutical companies will have assistance programs. It's a matter of filling out some forms, and if you meet their criteria, it can be very helpful and very cost-saving. I believe I'll turn it back to Liz at this point.
Thank you, Dr. Rizzo. It's time for another audience poll before we hear more from Dr. Rizzo. Would all of you in our audience please respond to this question? Do you use a COPD action plan to help monitor your COPD? Your possible responses are yes, no, or other. And if you want to use other, just go ahead and type into the Q&A box and tell us what's on your mind. Again, just circle the answer that corresponds, the circle that corresponds to your answer. While you're selecting your answer, let's hear from Karen and Mike about their experience with COPD action plans. Karen, do you use a COPD action plan?
Yes, I definitely do. I have used it for several years, ever since I first heard about it. And in my case, I have a physician, well, both a primary care and a pulmonologist, who have worked with me so that I understand when I'm beginning to exacerbate. I understand what my triggers are. And they have allowed me to, at all times, have a script for an antibiotic and for prednisone. They trust me enough to know that I won't use them unless it's necessary. But it makes it easier for me, back when we could travel to conferences and workshops, because on a Friday night, which is inevitably when you get sick, and there's no doctors, there's nothing available. You know, if I'm gone, I've always got that medication. And I can look at the action plan, think about what my doctors and I have talked about, and decide, is it time to use it? If I start using it, I always let my doctors know that I have started to use it. And if I'm no better in, say, 3 days, or if I'm getting markedly worse, then of course I contact them again, make an appointment, and go in. But I've been able to keep myself out of the hospital, keep myself from having to go even to an urgent care facility for many, many years by using the action plan. And I'm sure Dr. Rizzo is probably going to explain it even in more detail. But, you know, there's green when you're doing fine. There's yellow when things are not looking so good and you need to start taking, you know, perhaps your special medications. And then there's red when you're in trouble. And I think that there is, I think the next slide actually describes all of those. Anyway, it's wonderful. It's helped me tremendously.
Thanks, Karen. It's really great to hear your experience and for you to share so much how it has been for you to use a COPD action plan. Mike, do you use a COPD action plan?
No, I don't. Karen and I know each other. We've known each other for the last 3 years or so, being involved with the ALA and the patient advocacy group. And knock on wood, again, not to divulge Karen's information, but I'm not as severe as Karen is. I was just diagnosed 5 years ago, and I don't have the difficulties that Karen has. I don't have oxygen yet. Now, when it comes to managing, I do carry my albuterol wherever I go. It's one of those, if you keep it in your back pocket and you're outside working and you need to take a puff, which I've only had to do a few times in the last 5 years, but that panic attack type thing where Dr. Rizzo talked about earlier can really trigger you. And if you can't breathe, which I'm sure if you're on this conference call, some of you have been in that situation before where you panic, and if you don't have your medication handy, it even sets it off to another degree. So my action plan is to carry my albuterol whenever I'm doing anything, driving in my truck, whatever. I just carry it with me. I'm sure I'll be calling Karen in another few years to get some tips on how to do an action plan. But at this present time, the only thing I do is carry my albuterol and make sure that I don't do anything, as I said earlier, stupid.
Thanks, Mike. We really appreciate your perspective. Let's take a look at the results of our audience poll. So it looks like 28.2% of you use a COPD action plan to help monitor your COPD. About 56.4% of you don't. And for other, I'm sure some of those folks are educators and so on. But I did get some great comments in the Q&A box. Joanne said she was not sure what a COPD action plan was. And Joanne, you're in luck because Dr. Rizzo is going to go into that and explain it a little bit, and you'll get to see one. Patty said that she didn't understand the question, but that she actually has a COPD action plan. It just kind of wasn't called that. So we appreciate it as you guys type into the Q&A box, sharing your perspective. And it looks like we have a BBC facilitator who mentioned that she has distributed the COPD action plan to the folks in her BBC, which is wonderful. Okay, that looks like about most of the responses. Thank you, everybody, for just continuing to type into the Q&A box and send us your questions. It's just great. Dr. Rizzo, we're looking forward to hearing more about how to stay on track with COPD management.
Okay, well, thank you, Liz. Just want to comment on the interaction there between our two patients. I think they bring up two important points that one I've already stressed is that, first of all, every patient with COPD is different. Not everybody's going to benefit from the same drug, the same device, same number of drugs or devices. Not everybody's going to be as short of breath or need oxygen. So it's a very diverse disease, although there's a lot of common denominators, but it treats each patient differently. And I think that's important for a COPD action plan to help a patient figure out where their particular disease puts them and what they need to do. But it also helps promote the discussion between the treating physician and the patient. And Karen has a very good working relationship with her physician. She's allowed to have some medications on hand because she's built up some trust and needs it at times. And again, that only occurs when a patient has built up enough communication with that physician so that they know what the patient's going to do with the drugs that they give them. So I think a COPD action plan is a good way to start putting down a communication between you and the treating physician. Now, on this slide, that COPD action plan has very, very small font, and you can't see it. So we're going to go to the next slide, which kind of blows it up a little bit. And this is really, Karen started going over this, but the action plan is designed very much like an asthma action plan. When you're doing really well, you should be in the green zone, and that means that your normal level or usual level of activity is there. If you're coughing or bringing up mucus, it's your normal amount. You're doing well with your sleep at night. You're eating well. You're on all your medications. Your oxygen use is stable. So all of those things indicate that you're in a pretty good zone with regard to your COPD, and you just maintain the medications you've been kept on. The yellow zone starts to put up a little bit of a sign something might be brewing, and this includes just a little small font here as well. But now you're starting to notice a little change in your breathlessness from your typical baseline. You may have a little more cough and mucus than usual. Maybe you're noticing some ankle edema. You don't feel as good with regard to your sleep quality, your eating quality. So there's a number of things that are starting to be triggers that may indicate a call to your doctor or maybe an adjustment in medication. Maybe you need to use your rescue inhaler a little bit more based on the symptoms. If you've been given a prescription for oral corticosteroid like prednisone to take for when you're starting to have a flare, consider that. Usually if that's given to you by your physician, often they will say, if you think you need to start it, go ahead, but then let me know. Let the physician know that you're starting it. Antibiotics may or may not be on hand, and it's hard to know if you have an infection that's triggering these symptoms, or is it due to a change in the air quality, humidity, a little bit of poor night's sleep, mucus buildup. So all these things start to have questions that should be getting ready to you ask your physician whether or not you need to make changes in this regard. We go on then to what would be the red zone. This is where all those symptoms that you started noticing in the yellow zone have progressed despite any adjustments you made in the use of your rescue inhaler or starting the prednisone. And this is where you definitely need to be prompting a call to your physician, preferably not having to rush to an emergency room, but obviously if you have to, that's the thing to do, or call 911 if there's nobody around to help you. So again, the action plan puts everything in perspective of a traffic light, green, yellow, and red. And it's important to be, again, communicating all the information with your physician. And this, I believe, is downloadable from the American Lung Association. It's some basic information about your COPD management, medications, some of your vital signs, and some of the vital information. And again, that should be part of your medical history. And I believe we're on the next slide now. We're going to move on to switching gears a little bit. We're going to get back to talking about COVID-19. I mentioned earlier on the 2 to 4 day period of time when symptoms could be present after you've been infected. About 80% of the people who get infected with COVID-19 have very mild to minimal symptoms. 20% will end up needing to be hospitalized because they require oxygen, and a smaller percentage, anywhere from 3 to 5%, might need to go to the intensive care unit. And currently, right now, the fatality rate is a little around 1% of the people who ultimately do not survive with COVID-19. The symptoms are mentioned here. Cough and fever and shortness of breath have been expanded to the other symptoms you see on the list. Certainly, just as I mentioned in the COPD action plan, when you start having the below symptoms, you need to seek medical attention. There has been some evidence that progression of symptoms from COVID-19 can be very rapid, especially with regard to some oxygen changes. So these are the kind of things that you want to alert your physician to or seek medical attention to 911 or going to an urgent care center. if you've been diagnosed or think you may have COVID-19, but you're not having the symptoms that require hospitalization, the main thing is to keep track of those symptoms. What's changing? What do I do if a certain thing changes with regard to my fever, my cough, my chest pain, my pulse ox? All of those symptoms have to be taken into account. And I know in my institution that we have somebody who's presumed or has confirmed COVID-19, but is able to stay at home initially. We monitor them regularly, either through phone calls or there are texting modules that can be used. And I know my institution has 3 to 4 times a day, there's some texting back and forth with patients to a healthcare provider to make sure symptoms are being monitored. And that'll vary from place to place. If you are identified as having symptoms and were directed to care for others at home, you have to make sure isolation is taken into account, and at least 10 days have passed since symptoms. We used to monitor fever as well, but 10 days is certainly the thing to keep track of, because people can carry the virus for a period of time even after the fever is gone. The next one, I think we're to the point where we're going to have questions, and Karen and Mike are going to help with that as well.
Yes, they are. Thank you, Dr. Rizzo. We have learned so much today. If you have a question for Dr. Rizzo, please type it into the Q&A box. And while you're doing that, let's see if Mike and Karen have any questions they'd like to ask Dr. Rizzo. Mike, do you have any questions you'd like to ask Dr. Rizzo?
Yeah, one thing, Doc, flu shot, pneumonia shot, hopefully COVID shot, vaccine. Is there a particular order in which we should do this? I know the COVID's not ready yet, but
right.
How soon should I get my annual flu shot? Does that change as the year goes on? Do they come out with one strain in August, and then by October they come out with another shot? And then when it comes to the COVID, should I be the first one in line, or should I wait until it's a proven thing?
You're asking a lot of loaded questions here, Mike.
I know.
The flu shot recommendation right now is when it's available, you should get your flu shot. The earlier, the better.
Okay.
Very, very few times will the vaccines wear off before the flu season ends. So I would say go ahead and get the flu vaccine as soon as it's available. Most of the time, people start getting it by September, October. But if you have one late August, early September, and that's available, get that, because otherwise you may miss a chance to get it for whatever reason. The COVID-19 vaccine, optimistically, if it's going to be available, probably won't be till the spring of next year. And you asked all the questions that are unresolved right now. Who's going to get it? Who's going to set up the prioritization? Is it going to be free? Do you need one shot? Do you need one every month for 2 months? All the different candidates that are being utilized to create a vaccine have unanswered questions right now. And one of the big concerns is that the number of surveys done showing that even when a vaccine is available next spring or summer, half the people aren't going to take it because of concern over too rapid development, not safe, mistrust, government mistrust, science mistrust. So there's a lot of pros and cons there. My feeling is when a vaccine's available, I'm going to get one. And I think most of my patients with chronic lung disease should get one as well. The pneumovax is a separate issue, and that's something that your physician will look at your schedule and see whether or not, based on your age and your underlying lung condition, there are 2 different pneumonia vaccines, and they should be given in a specific order if possible. It's the Prevnar 13 and the pneumovax. So talk to your physician about what your immunization schedule looks like for that.
Okay, thank you.
That's great. Thanks for asking those questions, Mike. I know there were a lot of people out there with probably the same one, so I'm glad those came up. Karen, do you have a question for Dr. Rizzo?
Well, I have a comment. I read something today that indicated that the clinical trials that are now being performed for, I can't remember the name of the pharmaceutical company. I think it started with an M. It's here in the U.S. Thank you. You're right. Yes. And I read something that said that the vaccine may not get approved as rapidly as everybody would like because they are having difficulties in recruiting minorities and other groups of people to actually be part of the clinical trial. If this is true, are there ways that the ALA and other groups could reach out and try to encourage people to be part of the clinical trial? Because, it won't do us much good if they've got a good vaccine, but they won't release it because it hasn't been tested on enough people with enough variety of people, I should say, I guess.
Yeah. Even before the COVID situation, clinical trials for any drug, whether it's a lung drug, heart drug, have always had a difficult time recruiting enough minorities to make it look like it's a drug effective across the board. And a lot of that goes to the same things I just mentioned about the COVID vaccine not being accepted by everybody. Mistrust of the government, issues with science like the Tuskegee experiments on black individuals back in the 70s, cultural beliefs in anti-vaxxers, discussed with the government. There's all kinds of reasons. You're absolutely right that organizations like the American Lung Association, we are gearing up with a particularly heavy educational campaign between now and next spring to help get rid of some of the disbeliefs and get rid of the myths and work with community groups where the trust is, working with churches in the communities, neighborhood communities, community centers. We need to get information out that is transparent, science-based, and try to dispel some of the distrust that's out there regarding the vaccine. Now, the fact that it may or may not be approved for that reason probably is less important than whether or not we're going to have enough science behind it to show that it's effective. Because the whole idea for the vaccine to be proven is that you have enough individuals who took the vaccine, whether they're minorities or not, who can show that they did not get infected over a period of several months. And that's where the rapidity of getting the vaccine out to the market is hampered, because you do need time to see whether or not the vaccine is going to keep the people who got the real vaccine from getting infected versus those who got the placebo. So there's a lot of, like I said, uncertainty right now. Everybody's moving at a very fast pace, but the underlying problem is that the vaccine only can be shown to be effective if it keeps people from getting infected. So long answer, but people are working on it.
Well, I'm glad to hear that. And if there's anything that the members of Better Breathers, I mean, I'm speaking, for myself and Mike as members of the advisory group, but also members of local Better Breathers group clubs. If we can do anything to help, if the ALA will let us know, I'll do anything I can to help get the word out that it's safe, hopefully. No, I shouldn't have said that. The clinical trial is always safe. I've been in them.
Right. So, Liz, there's a lot of questions here. I didn't know if you wanted to sort through which ones you want me to answer first. We'll try to get to as many as we can till the hour's up, but then we can try to get back to you with other ones that we couldn't answer during the session.
We got some great ones, Dr. Rizzo. One of the ones is just a comment, and I would love any thoughts you have on this. We did have a person say that they don't have medical coverage. What would you recommend to somebody who is got lung disease and they don't have medical coverage? How can they keep themselves healthy and safe during the pandemic?
Well, unfortunately, they're not alone. There's a lot in our population where this is a problem, not only before the COVID-19, but certainly since COVID-19, when so many people lost their jobs and with it lost their insurance. Again, this is something where organizations like the Lung Association are advocating for help from the government, expansion of Medicaid rules, decreasing the requirements to get coverage. But many times these individuals need to seek out federally qualified health care centers in their community, urgent care centers that might be able to help out. But there's no easy answer for that person, unfortunately. But we know they're out there, and we need to work as really a community to try to get those people taken care of as well.
I appreciate that. Thank you. I did get a great question from Marianne, who said, if you can be away from your house at the time, is it okay to have a cleaning company come in during the pandemic?
I would say in general, yes. Most of what I've heard from other people is that cleaning companies are going out of their way to make sure they do everything they can in a very spatially distant manner, wearing masks, making sure that the people know they're coming into the house, they're wearing gloves, wearing boots. So I think it's best to be out of the house when they come in, but depending on who you get to do this, many of these cleaning companies are doing a very good job of following public health guidelines.
I appreciate that. Thank you. We got another great question from Terry, who said, if I have a family member who tested positive for COVID-19 antibodies and we've had recent contact, do we have to worry about getting COVID-19? In addition, do we need to stay away from that family member for 10 to 14 days?
Well, if your family member has antibodies, that means that they had the infection. It doesn't tell you when they had the infection. If it was fairly recent and they had no symptoms, they may still be contagious. I think the best thing is that whether or not the antibodies are present or not, certainly if they were present, you want to try to at least keep 10 to 14 days from when they may have had any symptoms at all until you get around them as well. Antibodies usually take a couple to 3 or 4 weeks to develop, but that varies from person to person. So having antibodies probably suggests a remote infection, but again, we don't know about reinfections. We don't know how long virus particles stay in the airway, so you got to be safe at this point. Be cautious.
Thank you. Here's another great one. Joanne asked, should people with COPD keep an oxygen monitor at home?
Yeah, that's a great question. That was asked a lot earlier on during COVID because there was this thing called silent hypoxemia that was portrayed a lot in the New York Times and some of the medical literature. There are patients who develop COVID-19 symptoms who may not be sick enough to be hospitalized at that presentation, but there are some that rapidly drop their oxygen level over the course of the next 24 to 48 hours. That's why I mentioned earlier it's important to be part of a monitoring system if you're diagnosed with COVID-19. Many hospitals are actually giving patients who are suspected of having COVID-19 a pulse oximeter to have at home for a couple of days so they can monitor them. So I would say if you have the resources to have a pulse oximeter at home and you have a chronic lung condition, it can be helpful. One more tool to kind of keep an eye on your symptoms and report back to your doctor if symptoms are changing. Not mandatory, but if you have a lung condition, it might be something worth investing in to have in your medicine cabinet, not just for COVID-19, but for any other flare-up that might affect your oxygen level.
Great, thank you. Here's another great one from Camille. How long after a swab test can you assume you're COVID-free?
Well, if the swab test is done on day one and you don't get a result for 7 to 10 days, you have no idea who you may be infecting by continuing to go about your business, especially if you thought you may have had the infection. So if you're suspicious you're infected and you get the swab test, you need to really stay isolated until the test comes back positive or negative. I think that's what I think I'm answering the question. I'm not sure, but
no, that's it. The question was, how long after the swab test can you assume you're COVID-free? I would assume maybe a negative test came back.
Well, the negative test coming back means you were negative on the day it was tested. It has nothing to do with 10 days later.
Awesome. Thank you. That's really an important qualification.
Yep.
Here's a great one. Just a little bit more information Susan would love to have about why a face shield is not recommended to prevent droplets from getting into the eye.
I would say it's not that it's not recommended. The science around using them is just very early. They really haven't been studied as much as facial coverings have. But I think even Dr. Fauci mentioned that a face shield does add that extra protection to the eyes that a facial covering doesn't. So a face shield can be helpful, used with a mask to protect the eyes, but probably by itself it should not be considered the best way because you're not only protecting yourself, you're worried about protecting others. The face shield does not protect others when you cough, sneeze, or talk and get things out from under that face shield. It's not as good as a facial covering, but it is protective to the eyes.
Great, thank you. Got a great question from Richard. What options do you have if your body will not handle steroids?
That's a number of people have issues with being on steroids because of the side effects. It depends on what you're being given the steroids for. Some people with exacerbations of COPD very often do need steroids. Sometimes it's almost a component of an asthma flare, and there are other eosinophil type reactions that can respond to other drugs that are on the market for asthma, but not particularly for COPD. And that's where a discussion with your physician comes into play, because some of these medications may need to be used off-label, so to speak. They're not really indicated for COPD, but they can be helpful in situations where the typical COPD drugs are not available to be used because of side effects. But that is a tough situation as far as the steroid need, but having side effects, unfortunately.
Thank you. Last question from Marcellus. Is Xolair a drug to consider even if you have well-controlled COPD?
Can you say the first part of that again? I didn't quite hear it.
Is Xolair a drug to consider even if you have well-controlled COPD?
Well, certainly if you're well-controlled, chances are you're not going to be considered to have a biologic added to your regimen. And Xolair is mainly indicated for asthma that is not controlled by the typical asthma medications and usually has a component of allergies with it, either an elevated IgE level or eosinophil level. Now, having said that, there are patients with COPD who have a mixture, who have a combination of asthma and COPD, and it may be that the Xolair will help your condition because the asthma component is really where the Xolair is being used.
Great, thank you. We had a lot of wonderful questions. Thank you to everyone who submitted those, and thank you to Dr. Rizzo for responding to those on the fly.
You're welcome.
If you enjoyed this webinar, we hope you'll join us for the next one, Natural Disaster Preparation on September 23rd at 2 p.m. Central. Just go to the Better Breathers Club page of the website to find the registration link. Please know you can always contact the Lung Helpline with any question about lung health at no cost. Our registered nurses and respiratory therapists are there to support you and provide the information that you need. You can also join an online support group at lung.org/community. We hope you take advantage of these resources in the days ahead. Thank you, Dr. Rizzo, for carving time out of your really busy schedule to join us today.
I enjoyed it.
You just offered so much information, and the clarification of questions was just outstanding. I know I speak for everyone when I say we all learned so much, and we're really grateful to have you share so much of your knowledge with us today.
Oh, thanks for asking me. You take care, okay?
Absolutely. Thank you to Mike and Karen for offering your perspective to our audience. I know they really enjoyed hearing from you about your experiences and learning how you're managing COPD during COVID-19.
Thank you.
You're welcome.
Thank you. Thank you finally to everyone who joined us on this call. We hope you all took away a few nuggets to make your journey ahead just a little easier. We wish you the very best during this difficult time and hope to welcome you to our next call on September 23rd. Please do take a moment to complete the webcast feedback form that will appear at the conclusion of the meeting. And we wish you all a wonderful day and goodbye from the American Lung Association.